Welcome, dear students. The topic of today's deliberation is pancreatic cancer, its risk factors and its management. The objectives of today's lecture are an introduction to pancreatic cancer, epidemiology and risk factors of pancreatic cancer, its clinical presentation, signs and symptoms, management of early disease, and management of locally advanced and systemically advanced disease. Dear students, let us first have an overview of the topic, that is pancreatic cancer. Pancreatic cancer is associated with a very poor prognosis, highlighted by the close parallel between disease incidence and mortality. 5-year survival in patients with pancreatic cancer remains as low as 6% in the USA. The low survival rate is attributed to several factors, of which perhaps the most important is the late stage at which most patients are diagnosed. Most patients with pancreatic cancer are asymptomatic until the disease develops to an advanced stage. Up to 20% of patients are eligible for initial resection. Even after potential curative resection, most patients will eventually have recurrence, and 5-year survival of completely resected patients is only up to 25%. Tumor biology of pancreatic cancer contributes to early recurrence and metastasis and resistance to chemotherapy and radiotherapy. Autopsy series have shown that about 90% of cases of pancreatic cancer are complicated by distant metastasis, as shown in the figure. To improve prognosis, a screening program for early diagnosis of pancreatic cancer is needed. Several risk factors for pancreatic cancer, such as family history of pancreatic cancer as well as personal history of cigarette smoking, chronic pancreatitis and diabetes mellitus, have been identified, but there is currently no standard program for screening patients at high risk. Dear students, here we discuss recent developments in epidemiology, risk factors, diagnosis and management of pancreatic cancer. Dear students, first the epidemiology and risk factors. The risk factors can be grouped as either host and environment factors or as non-modifiable and modifiable risk factors. Most host factors are non-modifiable, while the environmental factors may be modifiable to some extent. Host or non-modifiable factors. First, the age. Pancreatic cancer is predominantly a disease of older individuals. Pancreatic cancer is rare in the first 3 decades of life. After age of 30 years, however, incidence rates increase exponentially and peaks in the 7th and 8th decades. In the US, majority of the patients with pancreatic cancer are diagnosed between the age of 40 and 80 years, with the median age at diagnosis of pancreatic cancer being 71 years. The mean age of patients with early stage cancer is about 2 to 3 years younger than those with advanced stage cancer, suggesting that progression of cancer takes about 1 to 2 years to advance from early to late stage. In India, the incidence of pancreatic cancer starts to rise in the 5th decade and peaks in the 6th decade. Dear students, let's now discuss the role of gender in pancreatic cancer. The pancreatic cancer is 30% more common in men than women. The overall age adjusted incidence rate for pancreatic cancer is about 14 per 100,000 for men and about 11 per 100,000 in women. The incidence rates differ sharply among men and women between highly developed and less developed countries. Incidence rates of about 8.5 per 100,000 for men and about 5.6 per 100,000 for women are observed in developed countries, while incidence rate of 3.3 per 100,000 in men and 2.4 per 100,000 in women are reported in less developed or developing countries. In India, males are 1.5 to 2 times more affected than females. Several studies have evaluated gender-specific hormonal risk factors for a causal role in susceptibility to the pancreatic cancer. Recent studies concluded that reproductive factors are not associated with the development of pancreatic cancer in women. This suggests that the difference in pancreatic cancer rates between men and women may be due to environmental factors like smoking, although it is possible that there may yet be undiscovered genetic factors influencing cancer incidence and mortality in males and females. Dear students, let's now discuss the role of ethnicity in the incidence of pancreatic cancer. Race is recognized as a risk factor for pancreatic cancer. Significant differences in the incidence of pancreatic cancer have been reported between different races. In the United States, African Americans have a higher incidence than Caucasians, while the incidence is lowest in Asian Americans and Pacific Islanders. African Americans are also more likely to be diagnosed with advanced disease and less likely to receive surgery for pancreatic cancer. The higher incidence in African Americans has been attributed to differences in modifiable risk factors such as diet, alcohol, smoking, and vitamin D insufficiency. However, recent population-based studies have shown that the increased incidence of pancreatic cancer is not completely explained by the known and suspected risk factors, suggesting other factors that may contribute to the increased risk. These factors may include race-specific genetic differences which result in an increased risk of acquired mutations from known toxins, for example, in the ability to detoxify tobacco products. In a study comparing the oncogene mutations and biomarker immunoexpression between African Americans and Caucasians, the investigators found that African Americans had significantly higher rates of KRAS mutations to valine and lower rates of KRAS mutations to cysteine as shown in the figure. There was also lower expression of FAS and a trend towards higher immunoexpression to HER2 on immunohistochemistry amongst the African Americans. Chinese patients with pancreatic cancer have also been found to have different expressions of KRAS and P53 gene than Western or Japanese patients with pancreatic cancer. These findings suggest that there may be genetic and molecular differences related to race and ethnicity which may influence the incidence and biological behavior in pancreatic cancer similar to those seen in other tumors. These differences may also explain the difference in survival rates after treatment of pancreatic cancer in different racial groups. In particular, Asian patients appear to have a better survival rate than non-Asian patients. Longnecker et al. Studied over 10,000 patients with pancreatic cancer through the US SEER Cancer Registry from 1973 to 1995. Asian patients were found to have less aggressive tumors than either white or black patients. Dear students, this was about ethnicity. Now let us discuss about the role of blood groups in pancreatic cancer incidence. Large epidemiological studies have found an association between ABO blood groups and the risk of developing pancreatic cancer. People with blood groups like A, AB, or B have a higher risk of developing pancreatic cancer than people with blood group O. In support of these findings, a recent genome-wide association study has identified a common genetic variant at the ABO locus of 9q34 to be associated with increased pancreatic cancer risk. The pathogenic mechanism behind this association between the ABO locus and pancreatic cancer is, however, yet to be elucidated. Non-O blood groups may potentiate the risk of other factors like smoking. Dear students, let's now discuss the genetic risk factors of pancreatic cancer. Pancreatic cancer, like all other cancers, is a fundamentally genetic disease caused by both inherited and acquired genetic mutations. Genetic variations or mutations play an important role in both the familial and non-familial occurrences of pancreatic cancer. More than 80% of pancreatic cancer develops due to sporadically occurring mutations. A small proportion of pancreatic cancer cases are due to inherited germline mutations. First, inherited genetic mutations or germline mutations. Recently, some germline mutations have been recognized which have been associated with increased risk of pancreatic cancer in some genetic syndromes and certain familial pancreatic cancer kindreds, accounting for 5 to 10% of all patients. This has also led to an interest in identifying high-risk individuals who can then be screened cost-effectively to detect premalignant or early-stage tumors. Now, the familial pancreatic cancer. Familial pancreatic cancer is defined as at least 2 first-degree relatives with pancreatic cancer. The risk of pancreatic cancer increases exponentially with the number of first-degree relatives involved, ranging from 3-fold when 2 first-degree relatives have pancreatic cancer to 57-fold increased risk with 3 affected first-degree relatives. BRCA2 or BRCA2 mutations are the most common inherited mutations in familial pancreatic cancer, though other mutations like PALB2 have also been reported. Dear students, now the familial cancer syndromes. Increased risk of pancreatic cancer is also found to be associated with a number of familial cancer syndromes. These include FAMMM syndrome, hereditary pancreatitis, Peutz-Jeghers syndrome, cystic fibrosis, hereditary breast and ovarian cancer, etc. These syndromes are associated with germline mutations in certain genes like BRCA2, P16, ATM, STK11, PRSS1, SPINK1, and PALB2, which may result in a variably increased risk of pancreatic adenocarcinomas. Second, the acquired genetic mutations or somatic mutations. Genetic risk in non-familial pancreatic cancer. In addition to the inherited genetic mutations, acquired or somatic mutations in specific genes are responsible for pancreatic cancer development. There are 4 main genes affected in sporadic cancer, like KRAS, responsible for 95% of tumors, CDKN2A, that is P16, responsible for 90% of the cancers. Another one is P53, responsible for 75% of the cancers, and SMAD4, responsible for 55% of the cancers. The development and growth of cancer is a multi-step process, including initiation, progression, invasion, and ultimately establishment of metastatic disease. Similarly, the cancer of the pancreas originates in the ductal epithelium and evolves from pre-malignant lesions to fully invasive cancer. The progression from minimally dysplastic epithelium to more severe dysplasia and finally to invasive carcinoma is paralleled by successive accumulation of mutations that include the activation of the KRAS oncogenes and inactivation of the tumor suppressor genes. Full mutational landscape of pancreatic cancer was determined in a study that reported a comprehensive genetic analysis of pancreatic cancer. They found that pancreatic cancer contained an average of 63 genetic alterations, the majority of which were point mutations. The genetic alterations were involved in a core set of 12 signaling pathways and processes that were each genetically altered in 67 to 100% of the pancreatic cancers. However, not all tumors had alterations in all the pathways, and the key mutations in each pathway appeared to differ from one tumor to another. In the last decade, the advancement of molecular biology has improved our understanding of the pathogenesis of pancreatic cancer and characterized a number of genes that are mutated in pancreatic cancer that may lead to development of biomarkers and more effective targeted therapy. Diabetes mellitus. The association between diabetes and pancreatic cancer has long been recognized. Almost 175 years ago, a patient who presented with diabetes mellitus and died 6 months later from pancreatic cancer was reported. Since this initial observation, numerous epidemiological studies have reported that diabetes mellitus occurs more frequently in patients with pancreatic cancer than in the general population. Diabetes may be both a risk factor and a manifestation of pancreatic cancer. Long-standing diabetes has been shown to be a definite risk factor for the development of pancreatic cancer. Studies have shown that patients suffering with type 2 diabetes mellitus have an increased risk of pancreatic cancer if the disease duration is greater than or equal to 10 years. The table shows a summary of the cohort studies on the association of diabetes with pancreatic cancer. The risk increased progressively as 1, 2, or 3 or other potential risk factors were present in patients with newly onset diabetes mellitus, reaching 0.72% in patients with 3 risk factors. Recent studies suggest that hyperglycemia exposure to higher insulin concentrations and insulin resistance are associated with increased risk of exocrine pancreatic cancer. Now, the anti-diabetic drugs and the risk of pancreatic cancer. Emerging data from basic and epidemiological studies suggest that insulin may add to the risk for pancreatic cancer in diabetics. Ding et al. Showed that physiological concentrations of insulin increased pancreatic cancer cell proliferation as well as glucose use by activating MAP kinases and PI3 kinases. A multinational case control study by Massimo et al. Showed that patients treated with insulin had a relative risk of 3.54 compared with those treated only with oral hypoglycemic agents had a relative risk of 1.78 for developing pancreatic cancer. In contrast, metformin might have a protective effect with a decreased incidence of pancreatic cancer as compared to non-users. Soon after introduction, incretin-based therapies were found to be associated with pancreatitis and pancreatic cancer based on laboratory studies which suggested an adverse effect of these agents on the development of preneoplastic or malignant lesions of the pancreas, possibly related to the growth promoting effects of GLP-1 and its analog Axendin 4. However, a recent independent exhaustive evaluation by both Food and Drug Administration, that is FDA, and the European Medicines Agency concluded that the association of these medications with pancreatic cancer was unfounded and not consistent with available evidence. Dear students, let's now discuss the environmental or modifiable factors. First, the obesity. Obesity, defined as BMI greater than 30 or equal to 30 and increased BMI, are both risk factors for pancreatic cancer. A recent meta-analysis evaluated the association between obesity and pancreatic cancer in men and women and reported similarly increased pooled risk ratio in both obese men and women compared to those of normal weight. There are multiple proposed pathogenetic mechanisms for increased risk of pancreatic cancer with increasing weight. Obesity may be associated with physical inactivity, unhealthy diet and lifestyle, and yet undiscovered genetic factors which may play a role in increasing risk. At the cellular level, adipocytes may release potential procarcinogenic mediators like adipokines, IGF and VEGF, or result in chronic inflammation which might play a role in cancer pathogenesis. Now, the dietary factors. Since the pancreas is intimately involved in the metabolism of nutrients, there has been considerable interest in the possible etiological role of nutritional and related factors for pancreatic cancer in up to 30 to 50% of pancreatic cancers. There is an increased risk of pancreatic cancer associated with high consumption of meat, especially grilled, cholesterol, fried foods, and other foods containing nitrosamines. Similarly, an increased pancreatic cancer risk with high consumption of sugar-sweetened soft drinks has also been reported. On the other hand, a high consumption of citrus fruits and some flavonoids, which are naturally occurring antioxidants widely distributed in plants, has been associated with a modest reduction in pancreatic cancer risk levels. folate and methionine have a modest protective role against development of pancreatic cancer. The potential role of vitamin D in reducing pancreatic cancer risk has also been investigated. A higher 25 hydroxy vitamin D score was found to be associated with a 35% reduction in pancreatic cancer risk. Dear students, now the role of alcohol. Alcohol has long been suspected as a risk factor for pancreatic cancer because of its role in the etiology of chronic pancreatitis. There are a variety of effects of alcohol on pancreatic functions, on exocrine output, and on hormones. It is generally accepted that ethanol metabolism alters the intracellular redox state, which might play a central role in the mechanism underlying alcohol-induced chronic pancreatitis and pancreatic cancer. Ethanol metabolism through oxidation by alcohol dehydrogenase or through the microsomal oxidation system generates toxic metabolites such as acetaldehyde and reactive oxygen species. These metabolites may affect both the exocrine and endocrine pancreatic functions, activate pancreatic stellate cells to induce fibrosis, and cause the release of pro-inflammatory mediators, cytokines, etc. As a consequence, damage to the cellular organelles and genetic alteration may occur, which may contribute to pancreatic carcinogenesis. The epidemiological evidence for a causal association of pancreatic cancer with alcohol is, however, mixed. Dear students, now the smoking. Now the cigarette smoking has been definitely identified as the most important environmental risk factor for pancreatic cancer, with the population attributable risk reported at 25 to 35%. Unlike the lung, where tobacco smoke and tobacco degradation products are in direct contact with the pulmonary tissues, the pancreas is exposed to tobacco products indirectly. Tobacco-related carcinogens reach the pancreas either via bloodstream or perhaps through exposure of the pancreas to either duodenal contents or bile. Most pancreatic cancers occur in the head of the pancreas, and this region is where exposure to tobacco carcinogens contained in the duodenal juice or bile could occur. Passive smoking and second-hand smoke exposure has also been associated with pancreatic cancer in a dose-response relationship. In a large European prospective cohort study, exposure to environmental tobacco smoke in childhood was associated with twice the risk of pancreatic cancer in patients with no current or past history of smoking. Importantly, smoking has been shown to significantly potentiate the risk of pancreatic cancer in patients with other risk factors. Now the clinical presentation, signs and symptoms. Most pancreatic cancers have no symptoms in the early stage. A large case control study comparing the incidence of early pancreatic cancer symptoms suggested that pancreatic cancer is associated with lot of symptoms like weight loss, abdominal pain, nausea, vomiting, etc. Dear students, let's now discuss about the management of early disease. patients with pancreatic cancer are best cared for by multidisciplinary teams that include surgeons, medical and radiation oncologists, radiologists, GIT specialists, nutritionists, and pain specialists, among others. For patients with resectable disease, surgery remains the treatment of choice. Dear students, let's now discuss the management of locally advanced and systemically advanced disease. Approximately 30% of patients with pancreatic cancer receive a diagnosis of advanced locoregional disease, and an additional 30% of patients will have local recurrence of tumors after treatment for early disease. The treatment of patients with advanced locoregional disease is palliative. With current treatments, the median overall survival ranges only from 9 to 10 months. Management options range from systemic chemotherapy alone to combined forms of treatment with chemoradiation therapy and chemotherapy. A series of randomized trials conducted over the past 2 decades established that chemoradiation therapy was superior to radiation therapy alone in these patients. Chemotherapy is indeed the critical component in the treatment approach, and that combined treatment with chemotherapy and chemoradiation therapy is an effective though more toxic approach. However, randomized clinical trials of such combined treatments have had low enrollment, precluding a firm conclusion. The majority of patients with pancreatic cancer either present with metastatic disease or metastatic disease develops in them, mainly in the liver and peritoneal cavity. The treatment of patients with advanced disease remains palliative, although these patients should be offered the opportunity to participate in clinical trials evaluating new treatments when available. A meta-analysis of published findings from clinical trials showed an improvement in survival among patients who received chemotherapy. These findings suggest that active treatment is beneficial. For more than a decade, gemcitabine has been the treatment of choice on the basis of the result of the randomized trial of gemcitabine versus fluorouracil. Multiple new agents with diverse mechanisms of action in combination with gemcitabine have been tested in randomized clinical trials with no improvement in outcome. The only agent that in combination with gemcitabine has shown a small but statistically significant improvement in survival among patients with advanced pancreatic cancer is erlotinib, a small molecule inhibitor of the epidermal growth factor receptor EGFR. However, the high frequency of KRAS2 mutation in pancreatic cancer probably limits the benefits of an EGFR inhibitor. This limitation is similar to that observed in other cancers such as colon cancer. As compared with erlotinib alone, the combination of gemcitabine and erlotinib has more toxicity, particularly gastrointestinal symptoms. Together with the rather modest improvement in survival, the toxicity of this combination has limited its wide acceptance as the standard of care. A recent meta-analysis of randomized trials showed that patients with minimal disease-related symptoms and otherwise good health may benefit from combination chemotherapy with gemcitabine and either a platinum agent or a fluoropyrimidine. Thus, At the present time, the accepted treatment approach for patients with advanced disease is either gemcitabine given alone or gemcitabine combined with a platinum agent, erlotinib, or a fluoropyrimidine. Once the disease progresses, there is no accepted standard of care. Most patients at that point are too sick to receive any other treatment. In a highly selected group of patients with minimally symptomatic disease, second-line chemotherapy has modest efficacy, and it can be offered to patients with good functional reserve, that is, patients who are ambulatory and minimally symptomatic. Now, the future directions. There is much room for improvement in all aspects of treatment for pancreatic cancer. Screening of high-risk persons by means of either innovative imaging methods or measurements of serum biomarkers for early diagnosis is critical. A better understanding of the biology of pancreatic cancer is opening new avenues for treatment, and an increasing number of new targeted agents are in clinical development. These agents include small molecule inhibitors of oncogenes and signaling pathways such as RAS, SRC, and MEK, monoclonal antibodies targeting cell membrane proteins such as mesothelin and the so-called death receptors, and new nanotechnology and adenoviral agents. The recognition that the tumor microenvironment and cancer stem cells are critical components of pancreatic cancer has led to the development of agents such as the hedgehog inhibitors that target these components. The availability of preclinical models that recapitulate the complexity of this disease will probably help in establishing priorities and strategies for the development of new treatments. The complexity of the genome of pancreatic cancer indicates that it is a heterogeneous cancer and that methods to individualize therapy will be required. Dear students, this was all about today's lecture. Hope you have understood it well. Thank you. Goodbye.